Welcome to the Optum RX Pharmacy Insights Podcast. In this forum, we'll discuss the latest and most impactful events in pharmacy benefit management. Today's episode will focus on alternative funding vendors and the type of risks these companies may present for payers and members alike. I'm your host, Scott Draeger. Today, I'm joined by Mike Einodshofer, Chief Pharmacy Officer at Optum RX. Welcome to the podcast, Mike.
Thanks, Scott. It's great to be here again.
Mike, we've been, fortunate enough to have you join the podcast before. For the audience members who maybe hadn't heard any of our previous episodes, can you share with us a little bit about your professional background and what you're ultimately responsible for at Optum RX?
Certainly, Scott. So I'm a pharmacist. I started my career in retail and hospital practice. I currently serve as the Chief Pharmacy Officer with Optum RX. So my role at Optum RX is really to focus on how do we keep pharmacy benefits affordable and sustainable for plan sponsors and assure that members who need access to drugs, especially focused on high-cost specialty drugs, that members who need them have a way to afford them and have a way to, best chance of it possible for them to succeed on their therapy.
All right. Thank you for that, Mike. Let's really start from the beginning. What is an alternative funding vendor? And when did they start to pop up? Is this a relatively new phenomena?
Yeah, so it's a really fascinating, this is a bit of a complex topic. So I think before I can even get into what an alternate funding vendor is, I think we need to level set on how drugs are paid for today in the United States. And if you think about it, most people are covered for drugs under one of three ways. You're either in a Medicaid program, a Medicare program, or employer-sponsored healthcare, which is what we call commercial sector funding. A lot of people listening to the podcast probably have their healthcare benefits through their employer, and within those healthcare benefits is a pharmacy benefit. The pharmacy benefit then is when you go to the pharmacy counter and you give the pharmacist your ID card, they're billing a claim through the PBM, for that drug coverage. Now, on the other end of that transaction, there's an employer, and most employers of medium to large size, most employers are actually the ones that are ultimately paying the bill for that prescription. Some employers, especially small ones, they'll do what's called fully insured benefit, which means they'll pay a premium to an insurance company, and then their risk or their cost to provide that benefit to their employees is fixed because they're paying the insurance company a premium. And the insurance company takes the risk for what claims, happen over the course of a year within that benefit. But again, like I said, for most, mid and large size clients, they're what's called self-insured, so that if you go to the pharmacy and get a drug, your employer ends up getting a bill for that drug, and they end up, paying ultimately through the PBM, the pharmacy, for that drug. In that case, the PBM is hired to administer the benefits, coordinate the formulary, help facilitate the exchange of payments between the employer and the pharmacy, and a million other things. But the important thing to remember is at the end of the day, the employer is the one that's paying the bill. So what I just walked through, like Medicaid, Medicare, Medicaid, and commercial, then there's a very important segment. About 8% of people don't have any insurance. And for that 8% of the United States population, we're making good progress. I mean, just a few years ago in 2016, it was 9%. Now, 6 years later, we're down to 8%. But still, 8% is a pretty big number of the United States population that is uninsured. And that doesn't even begin to touch the number of patients that are functionally underinsured. So what pharmaceutical manufacturers have done, especially those that bring to market expensive specialty therapies treating, very serious, complex conditions like rheumatoid arthritis, cystic fibrosis, et cetera, they put together what are called, they work with charitable organizations, and there's certainly other, there's lots of charitable organizations in the marketplace today. Pharmaceutical manufacturers will work with those organizations, and sometimes, very specific organizations, to make sure that when a member or a patient or someone out there in the community doesn't have insurance for a drug, they have access to a charitable program that provides coverage for that drug for the patient. And so they work with these charitable organizations. They set up eligibility criteria that determine a patient doesn't have insurance coverage. And then the charitable organization, which many times gets its funding from pharmaceutical manufacturers and others, but manufacturers are a key source of funds for these charitable organizations. They end up then covering the drug for the patient that doesn't have insurance. So that's a very long background to get to your question. What's an alternate funding vendor? It's in the practice of administering benefits for employers, municipalities, unions today, the PBM, who PBM serve in the commercial sector. Over the last few years, there's been a crop up of different organizations that are going to employers and pitching them the ability for them to change or manipulate their pharmacy coverage so that the benefits they offer their employees don't cover certain specialty drugs because those specialty drugs have a charitable organization that the member may have eligibility for. That way, the employer doesn't have to pay for the drug. So this is obviously just a moral concern that we have, because essentially what's happening is we have individuals sensing a business opportunity to tap into charitable funds that are intended for underinsured and uninsured patients in the United States, and then commercializing it and then packaging it to an employer with the promise to lower their specialty drug costs without the employer, in my opinion, understanding how those programs ultimately work in the marketplace.
So, Mike, the pharmaceutical manufacturers provide some type of dollars to charities to help them, or to help patients who don't have insurance coverage subsidize the cost of the drug. Do pharmaceutical manufacturers know that these third-party vendors exist, these alternative funding vendors exist? And if they do know, what's their reaction to all this?
It's changing. So a couple years ago, when these programs first started to kind of make a name for themselves, it really started with really smaller employers, and manufacturers were, from what I could tell, weren't aware of these happening. And the charitable organizations, they're being presented, these consulting organizations I mentioned, right? They're helping the patients off. Usually they're representing the patients. The patients are forced to sign a release that allows these vendors to go represent them on their behalf. They apply for the charitable funds. And frankly, when the charitable organizations, when this was being done at small volumes, they simply wouldn't have been able to tell the difference between a patient that doesn't have any drug coverage versus a patient whose drug coverage has been selectively manipulated to make it appear that they don't have drug coverage for this particular drug. I would say since the programs have increased in their popularity, manufacturers are now becoming aware of the phenomenon, and many of them are asking themselves, how can we properly structure our policies and procedures around charitable eligibility so that we make sure that patients who truly need this sort of financial assistance have access to it.
Mike, can you provide some context for our listeners? How commonly are these types of vendors utilized by employers today? Any idea?
There's a good report from Pharmaceutical Strategies Group, or PSG. About 8% of plan sponsors use an alternate funding program today. The concerning thing is, in their survey, in their latest annual report, they report about 31% of employers are considering one of these programs. Now, I'd say within those numbers, there's probably, alternate funding might mean different things to different people that are responding to the numbers. But the numbers line up with what I'm seeing in practice too. I mean, how many times I get questions about this now from clients, as opposed to, a few years ago. It is markedly more in demand today. These programs are, I think, hitting a tipping point where manufacturers are paying attention now, because the proliferation of these vendors that are popping up, there's some 20 now vendors that are in the market trying to sell this type of service. I think that we're at a point where awareness is kind of getting very, very high. And, if we don't find a fair solution, right, and 31% of employers actually do adopt these programs, I think ultimately that jeopardizes the charitable funds that are available in the marketplace for patients that truly need them. And let's face it, it ultimately puts pressure on drug pricing as manufacturers kind of start to scramble to see how they can continue to fund charitable organizations while at the same time, meeting all their other financial obligations.
Mike, any idea how these alternative funding vendors are remunerated for their services?
Well, I mean, there's some public information out there. Adam Fine has done some really good work on drugchannels.net on an article that he put out about a month ago called The Shady Business of Specialty Carve-outs. I'd highly encourage anybody to go to drugchannels.net and take a read. I think he did a really good job kind of exposing a number of practices that these programs do. And then AIS Health or MMIT, more recently, a couple weeks ago, they had a nice article also. So according to both of those sources, these consultants or vendors are taking 20 to 25% of the charitable funding that they collect in lieu of the payer having to pay for the drug. They are then billing the employer 25% of that theoretical cost that the employer would have otherwise experienced. So that's a lot of money just to frame that up. If it's a $100,000 drug, let's say, and that's not uncommon for some newer cancer agents. If it's a $100,000 drug and 25% of that charitable funding would go to the vendor, that's a $25,000 payment to the vendor.
Mike, you talked about the ethical questions, obviously, here. Are there any other risks that an employer would have to think about, either for themselves or for their members?
Yeah. From the legal counsel that I've spoken with, and I'm certainly not an attorney, this is not legal advice, but I'd highly encourage any employer considering a program to do a lot of diligence on this, because there is a concern. A lot of these charitable organizations have means testing for the program, which means that based upon certain income levels, you may or may not qualify for the program. And there's some concern, I know, from a compliance standpoint that that raises that should be thoroughly understood. And that's kind of just scratching the surface, Scott. But again, I'd advise kind of a very thorough legal counsel review prior to anybody considering one of these programs.
Mike, can you talk a little bit about the patient experience? What is a patient experience whenever one of these alternative funding vendors are part of the equation?
Yeah, that's probably one of the most important questions, Scott. Thank you for asking it. I'm concerned with it a great deal, because we're adding another layer of significant complexity to a patient getting on a drug. Oftentimes that time is of the essence to get on it. Think about a newly diagnosed cancer patient who now has to go through an entirely another administrative layer of which they have no knowledge of how it works, right? That has to coordinate between the specialty pharmacy, the physician, the patient. The patient might have to provide financial information, tax documents in order to qualify for this program. And it adds a tremendous amount of stress and uncertainty into the patient experience. And I've seen it delay access to the initial fill by several weeks. And there's stories out there in the marketplace, that are, a lot worse.
Great. Mike, I really enjoyed our conversation. Thank you very much for spending some time with us today.
You're welcome, Scott. Thank you.
Thanks for listening to the Pharmacy Insights Podcast. I'm your host, Scott Draeger. Tune in again for more discussions as we examine the most important issues in pharmacy care services.